Hello, everyone. So I know every time you just get used that Dr. Jack is introducing the video, but I'm kind of intruder today. My name is Dr. Hosny. I am an eye consultant, like cornea consultant in the United Kingdom, and currently I'm the fellow for Dr. Jack at the moment. And I can't deny I learned a lot from him about DMEK, and he changed a lot of concepts that I was thinking about the DMEK and how hard it was, and I was using the DZEK for the hard cases, and now he completely reformatted my mind and my mindset about how to deal with this kind of surgeries. First of all, how are you, Dr. Jack? Welcome on your YouTube channel.
Yeah, thank you so much.
Thank you.
Honestly, it's been great having you.
Thank
Actually, for this past month, it really has been amazing. I mean, I hope I've taught you as much as you've taught me, actually, and it's been super fun having you. I mean, it's been great.
Thank you very much, Dr. Jack. You are very humble, like you taught me a lot. And thank you very much. So when I came here to and my colleagues, like in the cornea field, especially the young consultant and surgeons who are starting the DMEK, we were talking about a lot of questions that we need to talk about, to ask you for, and to help with us in starting our DMEK, or the people who are already in DMEK to improvise our DMEK, and for people who already doesn't do DMEK, like, and they are experienced consultant, what to say for them. So first of all, I would like to ask about, when we see you like using like kind of 6 meters graft, like this huge graft, like 9 millimeter and 10 millimeter graft. There is kind of questions about this, like of course about what is the reason you do this kind of big graft, and do you think it's very hard for us as like somebody who doesn't do the same amount, like if you do like 20-25 DMEK per day? So do you think for people who are quite not that experienced in DMEK can deal with the unfolding of this graft?
Yeah. Well, when we started doing DMEK, actually, when I learned it from Garrett, Garrett was doing DMEK when he invented it. Garrett Mellis, 9.75 millimeter graft for everybody. For everybody, got a 9.75 millimeter graft. And so the original DMEK technique was using a really large graft. And I don't know that I've ever discovered or invented anything ever myself. Everything that I know is something that I've copied from somebody else. And so we just try to copy Garrett as much as possible. When we started doing DMEK, my temptation was to use a smaller graft. A smaller graft is many times easier to open than a bigger graft. You have more room inside of the eye with a smaller graft. So I think when you're learning, a smaller graft can be good. But over time, you get a little bit more confidence and you want to try something new. You want to push yourself a little bit. And I started thinking, well, maybe a bigger graft would stick better, would have a lower rate of detachment, because we don't know why a DMEK graft sticks or doesn't stick. But whatever the mechanism, maybe it's surface area mediated, whether it's friction or pumping activity of the cells, something. So I thought, well, maybe your detachment rate will be lower with a bigger graft versus a smaller graft. So I thought, well, let's try to use the biggest graft we can. Let's use a 10 millimeter graft on everybody. And that hypothesis, bigger grafts stick better, is wrong. It is not true. Bigger grafts don't stick better. They have the same detachment rate, and they're harder to rebubble, okay? So they're harder to do, and they're harder to rebubble. But we still like big grafts, certainly bigger than what we used to use, for a couple of reasons. First is that they look so beautiful. An eye that's had a 10 millimeter DMEK, or even a 9 or 9.5 millimeter DMEK, you look at the eye post-operatively and it just looks beautiful. In the same way that, just like DMEK looks, in my opinion, it looks better than a DSEK. It's a more elegant, it just looks aesthetically better. And you look at a big graft and you think, this is beautiful, and there's something inside of you that just says you should be doing this. A more scientific, less aesthetic reason to use a bigger graft is that in some eyes, especially eyes that have a deep chamber, if you're post-vitrectomy, for example, it's much easier to unfold a big graft in those eyes because you don't have compression between the back of the cornea and the front of the iris. So if you're going to open the graft, you've got to wedge it somewhere, and it's easier to wedge the graft out in the angle with a big graft and unfold it than if it's spinning around in the depths of the center of the anterior chamber. So the primary reason I use a big graft is because it looks better, it's more aesthetic, but it is also very, very effective tool for unfolding in a hyper deep chamber.
So now you just tell us, Dr. Jack, about the benefits of having a big graft. But
Yeah.
for people who are just kind of didn't do this much surgeries,
Yeah.
what tips and tricks you say to them just to get into, start to do this big grafts?
Well, start slow, whatever size you're using now. You, instead of using an 8, use an 8.5 or 8.25 or something like this. So just sort of ramp up slow. And you may choose cases a little bit thoughtfully, which is to say you probably should start your big grafts in a pseudophakic eye or an eye that is in an elderly patient, people in their 80s or 90s. They have a deep chamber, kind of like they've been vitrectomized already. They have the syneretic vitreous, so you may think about doing a little bit bigger than normal in an elderly pseudophakic patient. That's probably a good way to start.
That's how good. So as well for the, just because we have, before I come here, I have a lot of questions for a new DMEK surgeons. So for the learning curve, like you have been doing DMEK surgery since years and years now. But like we most of us know how the learning curve goes in cataracts, in phaco, which I see it is not an easy surgery for the phaco.
Yeah.
Even because just we do it a lot, we find it an easy, but phaco is a very technical and very hard learning curve. What about the DMEK? You think like after how many cases, or like you feel that somebody can be independent in DMEK, or how long it take to get be like acceptable DMEK surgery?
I think cataract surgery is much more technically challenging than DMEK surgery. DMEK surgery now, I think there are just a few little tricks that you do over and over again. It's not nearly the complexity with cataract surgery. So I don't know what the learning curve is for DMEK, but I'm sure that it's easier to be a master DMEK surgeon than it is to be a master cataract surgeon. I'm definitely not a master cataract surgeon.
Yeah.
But in a way, I think it almost doesn't matter. How long will it take you to become a master? Who cares? Just start. Just start with it. And, you and I, Hosny, we've watched a lot of videos together, and we haven't watched any videos where I said, look, watch how this surgery was done perfectly. It's like every surgery that I've done, including you and I spent all day operating. We're going to watch our videos later, and I'm sure every single case will have mistakes in it,
right.
So I don't know how long it takes to become perfect at it, and I'm still really struggling myself, but it doesn't matter. And you can be safe, which is to say you could be on your own and operating and learning independently without somebody there watching you doing DMEK. I would say probably after just 5 cases, maybe 10 cases, because let's say you do DMEK and it doesn't work. Okay, who cares? You take the patient back and you do DSEK on them. Okay, it's fine, because if you do cataract surgery on somebody and it goes terribly wrong, the eye can be in a bad. You have to send them to retina, or it's a big problem. It's a big problem. Yeah. DMEK, everything is up above the pupillary plane. Everything is up above the iris. The graft, you can unfold it. It doesn't stick. Who cares? You just take the patient back and put a DSEK in them next week. They're not in any way worse. And you just explain to the patient, look, there's a new operation out there. It's called DMEK. It's really hard to do, but it offers some advantages. Let's try it and see if it works. If it doesn't, we'll do DSEK. And the patients are really understanding. It's super easy to try. Just have somebody with you your first couple of cases and then start.
Yeah, it's not the complication is more acceptable than what's happening in the phaco, definitely.
Right. Yeah, for sure.
So just for our colleagues and who are interested in step-by-step tips and tricks in DMEK, we have a video by the end of the conversation. Just Dr. Jack will explain some tips and tricks, to stay with us about this. I want you, just Dr. Jack, as well. We have kind of our professors who are like marvelous surgeons, like in the PKs and that can DSEK. But when the phaco started, we have some of our professors was resisting the temptation to start a new thing.
Yeah.
And the extracapsular was fantastic. There is no astigmatism with the stitches, but come on, you cannot you have to cope with the technology. You cannot use the landline now. You have to have your phone and stuff, mobile phone. So what you say for our like senior surgeons that like still they are kind of late in taking the steps for starting DMEK and think that DMEK is much better because they know how to do it well?
Well, DSEK is a much harder surgery than DMEK, I think. I think for me, if I were to do DSEK, I'd be much less comfortable and much more afraid of that operation than DMEK. I remember, we probably haven't done a DSEK in 4 or 5 years, but I remember when we had DSEK, I would be so discouraged when you had a graft detachment because you feel like, why? What? I mean, these always attach. Why is it detaching? And you feel so embarrassed and so bad.
Yeah.
And, we would take people back to the operating room to rebubble them with a totally free-floating DSEK. So I think if you are a really accomplished senior surgeon and you worry that DMEK is just more trouble than it's worth, it's actually probably easier than what you're doing now. Okay? It's probably less of a headache than what you're currently doing. And the other thing is that it's probably a little bit personality or temperament dependent. For me, if I do the same thing too long, I just get bored. I just feel like I want to try something. Can we get away with this? Can you push it? What happens if you try this? I mean, you and I were in the operating room all day today, and we did DMEKs, and it was fine. But we also tried a lot of things.
Yeah.
Some of them went well, and some of them did not go well. We definitely tried some new things today that didn't work. And you say, okay, well, it doesn't always work, but it's still a fun thing to try. It's just more enjoyable to try new things and learn new things than just to feel like, okay, I've learned everything I'm going to learn. I'm just going to keep doing this and gradually get older and get worse at this until I retire. I mean, why not just push yourself to try to do something a little bit more fun now and enjoy doing something new?
That's right. Do you yourself do DMEK now, Dr. Jack? You just kind of you abandoned it completely, like you don't do it at all?
We have done probably 3 or 4 DSEKs in the last 5 years or so, but they've all been to patch perforated corneal ulcers. So you can put a DSEK in the eye to patch a corneal perforation. It's really easy to do. You can either push it through the perforation or you can just drag it in the eye like you normally would. And that works a lot better, I think, than a tectonic graft, especially if you have a peripheral corneal perforation. If you have a near limbal corneal perforation, those patients are going to do terribly with a patch graft where you have to do some 5 or 6 millimeter graft into the limbus, or some giant eccentric 8 or 9 millimeter graft where you have the edge running through the visual axis or something like that. Those patients have terrible visual results. The operations are bloody. They look gruesome afterwards. But you can put a DSEK into the eye and patch the perforation internally and put some amniotic membrane over the top. And those eyes don't have stitches. They don't have problems with epithelializing afterwards.
Interesting.
You don't have to worry about rejection. Even if the graft rejects, it's off peripherally, so the opacity doesn't affect the patient's vision. Yeah. So that's a much nicer operation than sewing something into a melted corneal periphery.
So you use it for mostly for perforation, which are on the limbal side anyway. Just as long as we open this topic, we were talking about something interesting. Like I was having the opportunity to work in Queen Victoria Hospital. I was a fellow there, and we have the hardest case ever. Like you can see, like very complex cases, and we see a lot of perforations. You tell me something interesting that you use the amniotic membrane from the inside of the eye. Can you talk about this, because like this is very interesting, at least for me?
Well, this is not an idea of mine. This was an idea that my dad just casually mentioned one day. It's because I remember when I was a resident, I was sewing up some eye. I'm not sure what, I don't remember what was happening or something like this, but it was an eye that I just sewing up the interface, and I couldn't get it to stop leaking. And my dad, who is, taught me everything that I know, he was there and he was standing over me, and I was complaining that I couldn't get the eye to stop leaking. And what do I do? I've already put all these stitches in so many times. What can I do? And he said, well, why don't you just take amniotic membrane inside the eye and just patch it internally with amniotic membrane? And I thought, I've never heard anyone say that before. And I've never seen that published anywhere. But it works. You can put amniotic membrane in the eye. It's not poisonous. It's not toxic. It's not going to damage the endothelium. It won't fibrose into the angle. You can put it inside of the eye, and it's very effective as this plug to stop to stop a leak than you can patch an eye with internally. You probably have the amniotic membrane on hand in the clinic or in your surgery center. So if you have a perforation, you can just drag amniotic membrane inside and put it up against the pack of perforation, and it'll stop it.
And
from
you
leaking.
bubble it like you,
Yeah.
you go, yeah, okay, that's a good idea. We'll try to
Yeah.
to use this thing. What's your thoughts about the endo art? Have you tried it before, like, or
It's very weird because it's something I've discussed with Garrett before, and it's weird that it would work. Why does it work? You know, on the one hand, you look at the pictures and it seems to work. You know, the OCT does seem to be better. It's not perfect, and very rarely do these eyes achieve 20/20 vision. And you look at the cornea and it looks better, but not perfectly better, and you're just wondering what exactly is happening here. My honest answer is that it's confusing to me why it's working. It means we have some fundamental misunderstanding of how the cornea works. But I'm not particularly motivated to do it because I don't think that the vision is as good as DMEK. I think your rebubbling rate is much higher than it is with DMEK. I'm suspicious of prosthetic material in the cornea. You know, you put some artificial plastic in the cornea. It never seems to go well. Plastic on the back of the cornea, I also worry about that. But you know, the biggest advantage I know of the endo art is that, well, maybe the operation is easier to do than DMEK. That's not a real reason, because DMEK, it's just learning the tricks. Once you learn the tricks, it's an easy surgery. It's just you just have to know the tricks. And the other thing is tissue scarcity, tissue availability. I don't know that that's a serious argument, though, because there are operations like quarter DMEK, which is where, you know, Garrett Millis invented. You take one endothelial graft, you divide it into 4 pizza pie shaped pieces, and you transplant each of these 4 triangle pieces into a different eye. So you can use one endothelial graft for 4 different patients already now. So I just don't know that there's that much that's going to propel the operation, especially in a place like the States where you already really have enough tissue, and this seems to have a higher detachment rate and worse vision. But it's interesting to think about because it means that there's something there, and it means we don't really understand the cornea as well as we should.
so you think that like it's the same idea? I don't know, like, you know, when there's some I can't remember the name of the surgery, but when there is a central focus, just surgeons just do this matrixes for the center, and it heals. Probably there is some idea about just removing the unhealthy endothelium. It can make it better, so that's maybe it works. I don't know.
Yeah, well, it's interesting. So the decimatorexis only was reported at a congress in France by a French cornea specialist named Louis Parfique back in the 50s or 60s. So this was like 70 years
50s,
ago.
okay.
He described Decime's stripping only
Yes.
publicly in a scientific forum, and you can find his original article on PubMed. If you search Decime stripping only, you will find it mentioned like in the 1950s in the articles. So, you know, you think that like scientific publications now represents the distilled information of everything that we know about the eye. And every year we learn more and more, and our understanding grows and becomes more sophisticated. And then you realize actually there are really important things that people have figured out and nobody ever paid any attention, and it's forgotten. It's published and it's forgotten. So that's something you and I have talked about. You read the PubMed database now, you read the published literature. People are just publishing articles randomly. They're publishing them to put them on their CV. They don't mean anything. They don't even believe that they're true half of the time that they write them. But that didn't used to be the case. It used to be in the 1950s or whatever. You would just write an article if you had a bona fide good idea.
That's right.
And the articles were not confounded by all this dense, terrible academic jargon. They were readable and enjoyable and interesting and provocative and true. And so you go back and read these articles from the 50s or 60s, and you'll see the articles are enjoyable to read, and they contain stuff you've never heard of before, you know, which is kind of amazing.
I completely agree with you with that, because nowadays you have to have like some target to do some publications, and even if you come to the interview, sometimes in some places they don't actually care about how surgically skilled you are or how knowledge you know or stuff like that. How many publications you did? Maybe the publication is nothing, but like that is like I did 500 publications. So what is the other publication? As you say,
Right.
maybe before it was every publication was count. It's not just like by numbers as sometimes it had been measured nowadays.
Right.
There is few situations in the DMEK surgery, like when it happened, it just kind of make it messy, and I want to know your thoughts and what to do with. First of all, the fibrin in the anterior chamber. I want to know, because we talked about this before and you explained for me about it, where it come from. But I want to know, just like for me and my colleagues as well, to know again where it come from and what's the main source of fibrin, and your thoughts about the TPA and enoxaparin
Yeah.
in treating that, and how you manage when you have a fibrin.
Yeah. Well, we obviously do a lot of DMEK, and fibrin is a legitimate bona fide problem. It's real. It's not made up. It's not your imagination. It's an actual real problem, but it's super rare. I mean, we encounter it maybe, I'll do 1,000 DMEKs a year. We'll see it once every other year or something like that. It's very, very uncommon to have a case frustrated by fibrin. And where fibrin comes from in the eye, in my experience, it's not just bleeding. It's not bleeding in the eye, okay? It's specifically bleeding from the trabecular meshwork, okay?
Yeah.
So if you make a big iridotomy and the iris is profusely bleeding, you don't get fibrin. If you make an iridotomy and you go through the iris and munch the ciliary body, and the ciliary body is just hemorrhaging into the eye, you do not get fibrin.
That's interesting.
Okay? But where you get fibrin is when you score too peripherally and you dig into the trabecular meshwork. And unroofing the trabecular meshwork, that's where you get fibrin. So it's being sloppy in the decimeter rexus. And sometimes you get horrific fibrin in the eye. And it's a major problem because it wraps the graft up and the graft cannot be unrolled. I mean, the fiber strands that are enveloping the graft are stronger than the graft themselves. They cannot be pulled off the graft, and the graft cannot be opened. The sign of fibrin in the eye is not, I'm having difficulty unfolding the graft and there was bleeding. The sign is a non-patterned graft configuration. Grafts normally can occupy one of just a very small number of different configurations in the eye. There's the single roll, there's the double roll, there's the bouquet, there's the square. It's very small number of predictable ways the graft can fold in the eye. But if you have a graft that's weirdly kinked or doubled over or folded back or pinched in a way that's not a familiar pattern, there's something that's making it do that. There's some outside force intervening on the graft. So that's the key sign, is there's been bleeding in the eye and the graft is somehow occupying a very weird, not normal shape. Now, what do you do when you have fibrin in the eye? I don't know. I don't know what to do because the graft, you have to remove it from the eye.
Yeah.
And maybe you can try to pick the fiber strands off, but it's a bona fide disaster.
Yeah.
One thing you may try to do, I think if I had infinite access to resources, what I would do is I would take the graft out of the eye and I would probably rinse the graft in heparin or enoxaparin.
Yeah.
I would not squirt the heparin or enoxaparin into the eye.
You won't.
Because I worry too much that if the cause of the fibrin was bleeding, and you inject the heparin into a bleed. Now, I haven't used it, so maybe this is dumb, maybe this is not true, but I worry that it would cause the bleeding
More
to get
bleeding.
worse.
But makes sense.
But I would consider using it on the graft itself after I took it out of the eye to break whatever fiber strands were on the graft.
Yeah, that's a good idea.
And people do message me every week. They email me every week, multiple times a week, asking me about heparin or enoxaparin for DMEK graft unfolding. I don't think that anyone argues that it makes the graft stick better, that it reduces your detachment. I think what people argue is it makes the graft easier to unfold. And it might. But it's kind of like training wheels also make your bike easier to ride. It's probably true, but when you get to be an adult, you just don't need them. And that's not to say that, and that's maybe a little bit overly negative, but it's just to say that DMEK graft unfolding is not some miserable problem that you have to beat your head against the wall and come up with some exotic solution. It's just a handful of really simple tricks that anybody can do without needing to do some kind of special thing.
I remember when I asked you this question in the operation theater, you tell me, Hosni, just be quick.
That's also
As if
true.
like whatever, just
Well,
be quick.
it's actually something I learned from you. You know, if you have bleeding in the eye, rather than thinking, okay, well, let me get the heparin or the enoxaparin, or let's mix it up, or let's whatever. What you want to do is just unfold the graft quickly, because the longer you screw around in the eye and you're tapping and jets and that sort of thing, the more problems you're going to have. The more quick you are, probably the safer.
I completely agree. That's in every surgery, even in the cataract surgery. Like the more some people just like to spend more time. It's good to be spending your time, taking your time, but after that, it will get like the cornea will get edema. Everything will be, the patient will be uncomfortable. Like it's a lot of things. So I agree completely with you.
Don't rush, but go quickly. It's kind of like, you know, I was talking to somebody about this the other day, and I said that if I told you I would like you to neatly write your name, okay, you would do a better job than if I told you I want you to sit here for 1 hour, and at the end of the hour, I'm going to judge you how neatly you wrote your name. It'd be better to do it quickly. It'd be a better job doing it quickly than spending an hour writing your name.
Of course, I will not reach your rate of being quick to do 20 DMEKs per day, but like I will be quick as much as I can anyway. So the other thing is the vitreous in the anterior chamber as well. Like, of course, it's kind of maybe it's more common than the fibrin, because like from the iridotomy, from other stuff. So what do you think? Like, if even somebody's doing cataract surgery, like phaco-DMEK, how do you deal with the vitreous in the anterior chamber if the graft is already inside?
I think in general, you want to avoid doing a vitrectomy. And that sounds weird and strange. If you have vitreous, what do you mean you don't do a vitrectomy? Well, if the graft is already in the eye, then if you're doing a vitrectomy, you run a risk of course, of vitrectomizing the graft, of eating the graft, you know. But if you're doing an anterior vitrectomy in the AC up above the pupil or the iris, and you remove vitreous, you're just going to have more come forward. So you have to do a pars plana vitrectomy, and yes, you can do that, you know, but it's just fiddling and fooling with the eye. It's just messing around in there. And better, unless you just have giant amounts of vitreous in the eye, is basically just to work around the vitreous rather than keep removing it. And the way you work around the vitreous usually is when you have vitreous in the AC, it's not some giant glob sitting in the middle. It's a little bit coming from the PI, or some little bit amount trickling around from the pupil. And what you normally do is you just work in the other part of the eye. You can just unfold the graft away from that vitreous, and once you have the graft mostly unfolded, you lift it up with an air bubble, and the bubble pushes the vitreous back, and it pushes the graft up against the back.
Happy days.
And you know, most of the time, when you have vitreous in the anterior chamber, you probably don't know. You know, I think if you go back and watch your video, you'll see a little pupil peeking various times during DMEK. So most of the time, you probably have vitreous in the eye.
And you didn't notice it, just was unnoticed. It was very nice.
Or you have a little trouble unfolding the graft, and you're not sure why, but you know, it goes fine, you finish up. So, I mean, it's usually a minor nuisance, and you don't need to waste a bunch of time vitrectomizing.
Oh, that's very good. And I can see we do the, you know, sometimes with the, we just mentioned that fibrin is, if you even injure the ciliary body, fibrin will not be a problem. But it's good as well not to have a bleeding while doing the iridotomy. So how you prevent the bleeding while doing the iridotomy as much as you can?
Well, you know, Garrett, the way he used to do his iridotomies is he would use the YAG laser a week before surgery. And that was nice because you wouldn't have a bunch of inflammation or agitation at the time of the operation, but you have to make the patient come back for the laser, and it's 2 separate visits. The other problem with the laser, I think, is it's tough for me to make a big iridotomy far peripherally with the laser.
Yes, that's right.
And so it's extra visits, it's extra work, and I feel like the iridotomy is not as good. So when we started doing a lot of DMEKs, we were doing them at the hospital in the city in which we work. And at the hospital, we would use the vitrectomy handpiece. And the vitrectomy handpiece is great because you can munch a far peripheral iridotomy one-handed way out in the periphery using the vitrector. And it's very controlled, it's very nice, but it's expensive. You know, the vitrectomy handpiece costs $150 per case or something like that. And if you're paying for that, then that is a big problem, you know. So and then also you get bleeding, you know, sometimes you get bleeding. So we heard, however, you know, we had this Ertley phaco machine which has a capsulotomy function that you can use. It's a radio frequency diathermy probe that you can use for making a capsulotomy. Well, we don't really use it for that, but it makes a great iridotomy. So it cauterizes a hole in the iris. It's one-handed. It's reusable. So it's super nice because it costs nothing and makes a bloodless far peripheral iridotomy.
Cauterize while it's like doing
It comes on the phaco machine, so that's what we use for phaco. It's what we use for our DMEK surgeries. If you already have a phaco machine, you have to think, well, gosh, do I have to buy a phaco machine just to get access to that technology? That's why actually is your idea, Hosny, that they should take that radio frequency diathermy and just make it its own separate machine and just sell that own separate machine.
Yeah, I think it would be very handy.
Talk earlier about that. Yeah.
So now for the very interesting part, like as you know, the best thing we need to know as like anybody as like starting his DMEK, the tips and tricks and the step-by-step how to do. So luckily you have a good video now, and surprisingly you did the surgery. So let's open the video.
Well, it's actually both of us. We just did this operation together, maybe 2 hours, 3 hours ago.
Yes, 3 hours ago. I hope the setup, like putting the video in the middle like this, like it's looking nice. So yeah, I will leave you back to do the commentary. I might interrupt you a little bit.
Yeah, I think we should talk about it together. So this is completely unedited video. We operated on this patient just 3 hours ago in the office together, and we're starting the surgery. It's under topical anesthesia, but we're supplementing it with a subtenon's block. So this is actually our PA. We have an ophthalmic PA. Her name is Emma Scott, and she's great because she can help with the surgeries. We don't have a fellow, but she has been marvelous at increasing our efficiency because she can do things that free me up for operating next to her while she's working on this case. So the way we do the block is she anesthetizes the eye. She holds this Wexel sponge soaked in lidocaine up against the bulbar conjunctiva and just lets it sit there. So then she can grasp the conjunctiva and the Tenon's capsule with these toothed forceps and create a little peritomy using Westcott scissors. We inject about 1 cc of subtenon's anesthesia here behind the eye. And I think it's important not to inject too much. If you inject 2 cc's or more, then you increase the posterior pressure so much that you get a shallow anterior chamber and it's more difficult to do the descemetorrhexis and it's more difficult to do the graft unfolding.
Yep. So let's run a little bit. Now we see.
And she's injecting, that's a 19 gauge angiocath, and we like to use that as opposed to
Is this less traumatic?
a steel cannula because it makes it's more comfortable for the patients. They don't feel that sneaking back around the eye like that they do a piece of metal.
Yep. So I can see you start first by the paracentesis. Like how many paracentesis you usually do or you recommend?
I make 3. And I make 2 over here by me temporarily. I usually sit temporally when I'm doing these cases, sometimes superiorly, but it's just more convenient, comfortable for me to sit temporally. So I make 2 temporally and 1 nasally. And one tip that I learned from, there's this great cataract surgeon in New York named Dick McCool, and he shows that you should always turn the knife so that the bevel is superior. The bevel is superior. And that way, if the patient does a Bell's reflex and rolls their eye up, it doesn't lacerate the cornea. And it helps you when you're reviewing your video and you're trying to remember who is this patient or what happened during the surgery. You can identify if it's right or left eye according to how the bevel is.
That's a good idea. So you're trying to do the incision a little bit towards the up, like as if you are doing like a shallow chamber or something like that. It's not you going down with the MVR, you go up a little bit. You make it superior a little bit. So here we'll talk about the main incision. I see you do it like as a phaco incision, like you do 2 steps. You recommend this. And this is like 2.4 and you enlarge it a little bit?
I think ideally the wound should be maybe 2.8 or 3.0. We have lots of these extra 2.4 millimeter keratomes lying around and we don't want to throw them away. So we use them, but we just enlarge the wound to 2.8 or 3 millimeters. And it's nice to have a big wound because then the injector is loose inside the wound. It's not a tight squeeze. And if it's loose around the wound when you inject the graft, then you get leakage of fluid around the injector, and so it keeps the pressure low when you're injecting the graft.
It doesn't come
also, the other thing that's nice is it makes the surgery faster if the wound is a little bigger, because you can take the injector and just sneak it into the wound. You just kind of stab it right in there one-handed, whereas if it's a tight fit in a small wound. You have to grab the wound and pinch it and lift up and then stuff the injector in.
Yeah.
And so it's faster if you make it a little bit bigger too.
Yeah. So this trick that you are doing here in your office, I will steal it from you. Because it's a very nice, like always what was stopping us from doing under air. Because if you do under air the normal way that we used to, like you do like a small paracentesis and get it always leaking, it's time consuming, it's hard to be honest. And only when you do like AC maintainer, they connect usually to the vitrectomy machine.
Yeah.
And not everybody have the Constellation machine.
Yeah.
But I find your trick very nice. Like you get like a 60 cc and syringe and full of air, and your nurse or your assistant is doing this. And that's kind of really interesting when I see it.
It's not an idea that I came up with. I learned this from, there's this brilliant Singapore cornea specialist, Donald Tan.
Yeah.
And he was giving a talk about how he just mentioned this casually in one of his talks that he has an assistant hold a 60 cc syringe. And I thought, okay, that's brilliant. You know,
it was fantastic, to be honest.
The talk that he gave, he said it was actually about how to do DMEK.
Yeah.
And he said that the trick to DMEK is actually the same as the trick to a good marriage. He says it's actually it's all about manipulation and control. And I thought that was.
I think like hopefully his wife was not attending. So I can see like it's more visualization. Like if I do like usually I was doing it under BSS, like I go with the irrigation, but here you can see every detail. Like you don't leave any when you do the scoring this way.
Yeah, well, I mean, when you can see what you're doing, you know when to stop. You know, and if you are stripping under viscoelastic or BSS, you've stripped around a lot. You think you've got it all. Maybe you do. Maybe you don't. Maybe you've got most of the DMEK, or there are little remnants left behind. You know, you and I had a case today where there was a double layer of decimation.
Yeah, that was interesting.
So you strip off one layer, and then there's another one behind that you wouldn't see, except the fact that you've got.
You have some air. Like...
So you see some DMEK surgeons, they'll do decimeter excess and they'll pull it out and put it on top of the cornea and spread it out.
Yes.
And then, oh, look, I got it all but it doesn't.
So
mean
you have another one waiting for you.
Yeah. So the only way to know that you've got it all is to have it under
to
air.
have under air.
Yeah.
So now you did the scoring, and it's almost done.
Yeah. And it's very nice actually to use both hands when you're doing decimeter excess. It's much faster. Even if you think that you
you use both hands, like from here and from here.
Yeah. So even if you're really left hand dominant or right hand dominant, it's faster if you use both hands as opposed to using one hand.
So you go from one paracentesis, and
you
do
go
like
through one paracentesis and
and
go through the other half.
That's
And you feel like even if you're a little bit clumsy with your non-dominant hand, it's faster. Okay.
I watched like 150 case for you, and I didn't recognize.
Well, even in this case, if you go back and watch, you'll see that I come.
Well, that's really, thank you for
and because it's you just have better ergonomics. Okay. And also, if you start using your non-dominant hand with your decimeter excess, it'll make you better with your dominant hand because you'll be you just somehow internalize things more when you use your non-dominant hand. You just learn things a little bit better, and they translate over to your dominant hand.
Yeah, that's right. It's like something new for you, so like you try to learn it the right way.
Well, it's actually something Garrett taught me. He said that if you are doing something with your dominant hand, you're probably so skilled and dexterous that even if you're doing it wrong, you can make it work. You know, you kind of just make it work.
That's right.
But if you're doing it with your non-dominant hand, you're clumsy and it won't work unless you're doing it right.
That's
okay?
Right. That's
so
right.
your form is actually better when you do it with your non-dominant hand.
That's right. Because like maybe you do mistakes like with habits, like with the dominant hand, and after that, like you will avoid this mistake with the non-dominant. See, this is the interesting part, like the iridotomy, you just use the capsulotomy machine now.
Yeah, and it's so nice. It works. I mean, this costs us nothing. It's a free device to use. There's no bleeding ever. It's very precise.
And we have to make sure
very peripheral.
Yeah, very, very peripheral. Have to be very peripheral.
We do it right over the ciliary body, and the reason it's nice is because if you have it a couple of millimeters up, then you can't leave nearly as much air. You know, and if you can only leave an 80% air bubble instead of a 95% air bubble, you have less support for the grafts. You have greater risk for detachment.
Yeah. I just would like to say something about the capsule, the decimeter excess, because sometimes we are worried about leaving remnants. As we say, we do it usually with, I do it underwater, some colleagues do it under visco. So to make sure that what we do, we just like put some trypan blue or vision blue to see. I think this is more cost effective and it's better visualization.
Trypan blue costs us $60 a vial, so it's very expensive to use trypan blue. The other thing is that you don't see as well with the trypan blue as you do with air. I mean, so it just doesn't work as well.
Yeah.
And the third thing is that it can definitely stain the posterior stroma.
Oh, okay.
And that's why if I ever have trouble unfolding a graft, it used to be, especially when I was learning, you're doing DMEK, and you've been unfolding the graft for 30 minutes and it's still not unfolded, and you think, okay, I've lost all the stain, I'm gonna have to restain the graft. Don't ever restain inside the eye. Always take it out, because usually the cornea is swollen and edematous and you can't see that good, and the graft is poorly stained. And if you inject trypan blue into the anterior chamber, everything stains
blue.
The iris stains blue, the cornea stains blue,
including the graft.
The graft stains the least blue of all of those things. Okay, it's always better to remove the graft and stain it, and then
put it back.
Feels like defeat to take the graft out of the eye. You have to get over that psychological hurdle. It's better to take it out, stain it, and then put it back in, then stain inside. But the point is that when you inject trypan blue inside of the eye, you run the risk, and look, we do it sometimes, but you run the risk of worsening your visibility, not improving the visibility.
Yeah. I can see here something interesting, like I don't see you do often. You are hydrating the wound, probably?
Yeah. The reason I'm hydrating the wound is because the chamber is shallow, it's a phakic eye, and I was muddling around doing the stripping. It took me an extra couple of minutes. I mean, this is a 10-minute long case, but it took me an extra couple of minutes to do the stripping. And so sometimes you can stretch out the paracentesis a little bit. And in an eye where you've got maybe this leaking paracentesis a bit and the chamber is shallow and the patient is phakic, the real risk is you can't inject the graft, you can't unfold the graft because you can't deepen the chamber. So before I inject the graft, always what I am evaluating is, can I deepen the chamber? And if I can't deepen it, if I inject fluid and the chamber deepens and then shallows again, then it's leaking somewhere. And that's a major problem. You don't want to find out after the graft is in the eye that you can't deepen the chamber. You want to find out before the graft goes in the eye. So if I'm suspicious that the chamber is not stable for any reason, then I'll hydrate the paras, and I'll look and see, does the chamber stay deep, okay? So that's what I was doing here. I was hydrating the paras so I could make sure the chamber stayed deep in the shallow chamber so I could unfold the graft.
So that's for the most interesting part. Now you are introducing the graft. You don't have, I see you never check to have a double roll. Some people just make a big effort before the surgery to put it in the double roll position. It doesn't have to be.
Well, I remember years ago, I remember Garrett was invited to Harvard to give some talk about DMEK, okay? And he invited me to go with him, so we were both at Harvard, and he's presenting on stage in front of all of these doctors, and he says, what's the most important thing for unfolding a DMEK graft, okay? And nobody knew the answer. So then he calls on me, I don't have my hand raised, I'm just sitting there, but he says, Jack, tell everybody what's the most important thing. And I don't remember what I said, but it was the wrong answer, because what he said is no. He said the most important thing is to inject the graft as a double roll. Okay. So if you inject it as a double roll, then it's usually really simple to unfold it. Okay.
Yeah, that's right.
But my problem, the reason I don't inject it as a double roll, is twofold. Number one, I'm not very good at making the graft a double roll before I inject it. Sometimes it's a double roll, but then I aspirate it and I put it in, and it's somehow a single roll again. Or it's a double roll, but I can't really tell if it's right side up or upside down. And so I inject it and it's upside down. Or it's a double roll, but as I'm injecting, the chamber shallows and it gets wadded up. So I'm not very good at that. So the first thing is, even if I wanted to, I'm not very good at injecting the graft as a double roll. And the second reason why I don't is that I always think that, like, okay, yes, that makes the surgery easier, but what could you do to make the surgery harder? It's like, it's almost, not just because, like, inevitably you'll be in a situation where the graft is somehow in a weird configuration and you need to unfold it, okay? So rather than thinking that, okay, I have to have everything just right before I inject, and you fiddle with it and fool with it, just put it in the eye
That's like,
and deepen the chamber, and then it's a relatively easy problem to solve. You don't need to spend 10 minutes trying to preempt the problem when the problem is very easily solved.
yeah, it's like going to the gym. Like you have to challenge yourself with heavier weight. You don't every
it's
time
probably
doing
true.
the same.
Yeah, it's probably true.
Doesn't. So now you are injecting the graft.
Yeah, and I'm pointing it away from the pupil.
Away from the
and see,
pupil.
the graft goes in the eye, but it's kind of wadded up a little bit because the chamber is shallow. Okay, so then we'll deepen the chamber to get the graft to declare itself. It opens up. It's sort of a bouquet configuration. It looks vaguely right side up as we inject it. So I'm going to put some shuffle bumps
So
over.
how you know it's right side? I can see. Like, what is the signs to know? Of course, you have either the arrow mark or the S mark or whatever.
Yeah.
But like in this situation, how you know it's?
Sometimes you can't tell. Sometimes you legitimately can't tell. But oftentimes when you look down at the graft, you can just sort of see the way that the edge is curling. You kind of just get a little bit of a reflex. It's difficult to describe, but it's kind of just like if you catch a glimpse of the back of your mother when she's all the way down the hall, you just know that's who it is, you know. And it's just something that comes with the experience and whatever. So anyway, we inject the graft in the eye. You can just sort of tell by the way it's curling. Okay, it's probably right side up. You know.
So you just know what
So we inject the graft, and now it seems to be right side up. There's this single fold and a rolled edge. So this requires what are called Deerzheimer swipes, and we just sort of apply those little taps to the edge of the graft, and it just opens right up, and that's it.
Is it like like a 9.5, something like that? It's a big one.
Yeah, it's a big graft, but you see, it's a phakic eye. You inject it. It's just some random configuration, but super simple. Just to inject the graft and unfold it, and this is the way they all go. And you don't need, enoxaparin to make the graft unfolding easier or something like that. It's just you just need to learn the little tricks. This is not it's not rocket science. It's just a few little tricks that you do the same way every time.
And when you inject the air, you just make it completely full, like a hard.
Well, usually I want the eye firm, a pressure of 25 or 30 or something like that, and I try to leave just a little meniscus barely visible at the periphery.
And I can see the most important debate now we can talk about that I cannot see any stitches. Like, let's just. So I think we finished the video. Let's talk. So you don't take stitches, because I know even people not only take the stitches for the main one, they take for the ports as well. Like, so like, okay, do PK then. Like, what are you doing here?
Well, I think that. There are lots of reasons for that. First, if the wound is not leaking at the end of the case, why you're putting stitches in? It's kind of tough to figure out exactly why you're doing that. It's not obvious to me that you should do that and not do it at the end of a phaco. The logic seems to be more or less the same. Nobody does at the end of the phaco. It's more common to do it at DMEK, so you just have people doing it just because other people are doing it, but it doesn't really seem to be. So that's the first thing, is there's not really clear reason to be doing it. The other thing is it takes extra time.
They're like afraid that the graft might come back from the eye, or just like when he squeeze or something. It will never happen. No?
But it takes extra time. It costs money to put the stitches in the eye. And also you're distorting the cornea when you put the stitch in and you tighten it down. So you may be causing an irregularity on the back surface that inclines towards detachment. Also, maybe the patient doesn't come back and the stitch breaks and it gets infected, or it precipitates a graft rejection. Bad things can happen. When you are doing extra things inside of the eye, you can always think of some reason to spend an extra 5 minutes fooling with the eye, fiddling with the eye. But it's what we talked about 1,000 times, is I think that you shouldn't be rushing through a surgery. And I hope you watch our videos and it doesn't look like I'm rushing around. I hope it looks like I'm taking my time. But I think that going fast is usually safer than going slow.
That's right. Dr. Jack, I would like to thank you very much for letting me spamming your your YouTube channel and like making some of new videos that we're talking together like that. I've learned a lot from you. Thank you very much. And on the personal as well way, you're such now a very good friend. Like, and very happy to know such Like if you don't know Dr. Jack, really, like maybe you know from the video only, like on the personal way, he's very friendly, he's very honest. I'm really, it was a great pleasure to know you, Dr. Jack.
It's really the other way around. It's been great having you. It really has been amazing.
Thanks very much. So I'm waiting for more and more videos from you, and yeah, we'll see you next episode. Take care.